So maternal pelvis and fetal skull, starting with the diameters in the fetal skull, page number 227. So in the fetal skull diameters, what is the favorable position, the presentation that we see? कैसा होना चाहिए? Vertex, face की brow. कौन सा? Vertex. So the three presentations are vertex, face, or the brow presentation. The vertex head, it is flexed. It could be flexed vertex, deflexed vertex. Remember that whenever it's a vertex presentation, it is occipito, suboccipito, or occipitofrontal, suboccipitobregmatic. It will have this occipito or suboccipito coming in as the diameter. So the most common is the vertex presentation. And which vertex? Flexed or deflexed? Flexed vertex, completely flexed. And in that, what is the engaging diameter? Suboccipitobregmatic. Remember, it is suboccipitobregmatic, not the frontal. So remember it as most common. मतलब सब में दिखने वाला is सब. सब में दिखता है सब. Suboccipitobregmatic. The face presentation means the baby is like this. That's the face. So what diameter will you have here? Submento. Face means extended. So when they say it's complete extension is what presentation? Face. Face CE, complete extension. So in the face we will have the diameters which are submentobregmatic, submentovertical. The maximum engaging diameter is seen with what presentation? The brow presentation. Maximum, सबसे लंबा. What is the long car? What is the long car? Sorry, van. And what is the other long car? BMW. Remember BMW. What is BMW? That is in brow presentation. You have mento vertical, which is the longest diameter. So BMW brow has mento vertical, which is the longest. That's the maximum. Why do we prefer the completely flexed vertex? Because its diameter is minimum. Right? Suboccipitobregmatic is 9.5 centimeters. Completely flexed, matlab like this. And as the extension happens, the deflection happens, you will see the diameter is going on increasing. So suboccipitobregmatic, suboccipitofrontal, and occipitofrontal. So if you are given this diagram and you are asked, which of these is the engaging diameter in the brow presentation? So brow में क्या था? BMW. Mento मतलब chin. So this is mento vertical. This is the brow presentation. What is this one? Submento. तो कौन सा presentation होगा? Face. This is submento vertical. This is submento bregmatic. Bregma, here the area of anterior fontanelle. Which is the most common engaging diameter out of these? What's the number? 4. It is sub में most common is suboccipitobregmatic. So bregma वाला, पीछे वाला, this is suboccipitobregmatic. This is occipito. Where is this occipito going in the front? Suboccipito, occipitofrontal, occipitofrontal. So this is how you'll identify and remember the various diameters in the fetal skull. Coming to the types of maternal pelvis, gynecoid, enteroid, anthropoid, and platypelloid. Gynecoid pelvis मतलब गोल गोल pelvis. Gynecoid is rounded, गोल गोल. Platypeloid, platy is transverse. Platy is the transverse. That means which diameter is more? Transverse diameter more than AP diameter. Android is heart shape. Remember android. Android मतलब female की male. Male pelvis is heart shaped and male के हाथ कैसे होते हैं? मेल के दिल ऐसा होता है कि जो अटक जाएंगे किस पे तो अटक ही जाएंगे, राइट. डिफिकल्ट टू मूव ऑन. दे हैव डीप ट्रांसवर्स अरेस्ट. Deep transverse arrest is most common in android, which is heart. Remember, android ka heart, deep transverse arrest. So if I ask you that which pelvis has the converging side walls? Android. Converging matlab they are coming together like this. Right, so the transverse arrest will be common because it's converging, the diameter is less. When the AP diameter is more than the transverse, it is anthropoid. Anthropoid, AP more than transverse. And in anthropoid, face to pubis delivery is common in anthropoid. Anthropoid has face to pubis. So most favorable pelvis, of course, logically is going to be gynecoid. Gynecoid matlab the female pelvis, the goal pelvis. Least favorable, of course, is male pelvis, convergent side walls. Deep transverse arrest is common in male, the android. If you look at the pelvic inlet and the pelvic outlet, or these are the pelvic cavity. Pelvic inlet, what diameter is more? It's the transverse or the AP. Remember at the pelvic inlet, when the fetus head is engaging, it engages in what diameter? Transverse, क्योंकि ये ज़्यादा होता है. But at the outlet, it is the AP which is more. So when it has to come out, it has to come like this. So that is why engagement in the transverse, but it is coming out in this AP diameter. So what happens during the process? The fetus head rotates. To come out, it has to rotate. So remember that at the inlet, the transverse diameter is more. So the engagement takes place in the transverse diameter, while in the outlet, the AP is more. Hence, the 90-degree rotation takes place. Right, so do it. Like the more senses you involve when you are remembering something, trying to remember something, the better you remember. So if you do like this, you remember कि ऊपर वाला transverse ज़्यादा है, नीचे वाला AP ज़्यादा, right? So that is what is the transverse and the AP. Inlet is transverse more, outlet is AP more. Because outlet का shape कैसा होता है? Outlet, the pelvic outlet is diamond shape. The AP is more than the transverse. While the pelvic cavity is a circle. In a circle, all the diameters are same. AP ho, oblique ho, transverse ho. All of them is the same, 12 centimeters. Coming to this pelvis, is this Roberts or Nagle's? What is absent here? Sacral ala. One side, both sides. One side. You can see the sacral ala here. You don't see it here. One sacral ala absent is Nagle's. One is Nagle's. Nagler's reaction was Clostridium perfringens. What toxin? Alpha toxin. What is the toxin? Lecithinase. How does it act? Perfringens perforates, lyses the cell membrane. This is the vertebra or directly iliac blade है. The sacral ala is absent on both sides. Absent is Robert. Robert is by both absent. What conjugate are you measuring here? Diagonal, obstetric. Diagonal. Remember that when you're given an image like this and you're asking क्या measure कर रहे हैं. So this is what you are measuring clinically. It is helping you in the clinical assessment of the pelvic size to see that there is no CPD, the cephalopelvic disproportion. So remember that diagonal conjugate is what is the clinical conjugate. It helps in the clinical diagnosis. Clinical is diagonal. So logically thinking, the diagonal conjugate, this is the pubic bone here. You are measuring where? If this is the pubic bone and I am measuring the diameter. So it is what border, what margin of the pubic bone? Upper to lower. कहाँ से जा रहा है? Lower. So diagonal conjugate is from the lower margin. Because that's what is where you can touch the finger. So if you are given an image and you are asked कि ये line है, बताओ ये कौन सी line क्या बता रही है? This is the pubic bone. Lower wala will be the diagonal, the clinical. This is where we touch the finger. So remember, from top to bottom, it is tod. Top to bottom, it is tod. The true conjugate, the obstetric conjugate, and the diagonal conjugate. True, obstetric, diagonal. So true conjugate is how much, obstetric is how much, and diagonal is how much. Remember, all of this is 1, 1, 1, right? Either 10, 11, 12. So which is 10, which is 11, and which is 12? Remember, obstetric is 10. Diagonal 12. Di is 12. So baki bacha true. True T is 1. It is 11. So which is the minimum? Obstetric. Everywhere you would see that obstetric diameters is generally the term used for the diameters which are the minimum. So obstetric is the minimum. So how do you calculate the obstetric conjugate? Because clinically you are calculating the diagonal conjugate. So obstetric conjugate is 10, diagonal is 12. It is 12 minus 2 or it is 1 minus 1.5. So minus 1.5 minus 2 centimeters. So if they give you that diagonal conjugate in a female is 11, तो आपको 1.5 minus करके obstetric मिलेगा. Right? So some books give it as 12, some give it as 11.5. So minus 1.5. So minimum is the obstetric. Generally minimum is the obstetric. Coming to ectopic pregnancy. Ectopic matlab pregnancy occurring at ectopic site outside the uterus. For ectopic pregnancy, the most common site is fallopian tube. The most common site in fallopian tube is ampulla. Ampulla matlab the dilated part. If it is dilated, the pregnancy can grow well. Right? So nature itself tries to take it in the dilated part. Least common, interstitial. Where is the rupture most common? Rupture most common. The narrowest part, because अगर ये grow करेगा तो rupture हो जाएगा. Rupture is most common in isthmus has easiest, earliest rupture. Most common, earliest rupture, isthmus, because it is narrowest. Where will be the rupture? Late rupture? Interstitial. Interstitial matlab, if this is the uterus, fallopian tube, this part which is at the uterus is the interstitial part going into the uterus. So it is supported by the myometrium. Right? Whenever you get somebody's support, you have a lot of advantages. Where did we see this? Where did we see this? Support gives you a lot of advantages. ये तो बता दो क्या होता है? Indirect ophthalmoscopy. Remember, indirect ophthalmoscopy takes the support of condensing lens. It has all the advantages: hazy media, brightness, stereopsis, larger field of view, all of that. Except what advantage is not there? Magnification. Right? The magnification is 5x. Maximum risk for ectopic is with a previous tubal surgery. If there is a previous tubal surgery, any surgery affecting the tube, damaging that part, ectopic risk वहां बढ़ जाएगी. But previous tubal surgery is not as common as PID. What is more common that we see? PID. So most common is PID, but maximum risk is previous tubal surgery. So PID is more common, so that's the most common. So if you have a patient with suspected ectopic pregnancy, and if the patient is unstable, rupture हो गया, shock है, so stabilize and take the patient for laparotomy. Right, unstable patient, stabilize the patient and take the patient for laparotomy. But if it's a stable patient, what will you do first? Ultrasound. Which ultrasound will be better? Transvaginal gives the better images as compared to transabdominal. What will you see on ultrasound in ectopic? Uterus will be empty. Those are the words given. Empty uterus मतलब वहाँ pregnancy नहीं दिख रही है. But can I see a pseudo gestational sac? Yes, it's not a true gestational sac, but a pseudo gestational sac. How do I know it is not true? It is pseudo. It is centrally located, while a true gestational sac is eccentric. Central is pseudo. So there will be some fluid, right? It's centrally located, and along with that, where will I see the ectopic? The most common site, the fallopian tube. That's basically in the adnexa. An adnexal mass and adnexal sac is seen, which has this tubal ring sign, an echogenic ring surrounding it. Doppler में, if I do a Doppler, what do I see on a Doppler? Ring of fire. Right, Doppler shows the ring of fire, the peripheral vascularity like a fire. So if you tell me that Doppler में ये red और blue क्यों नहीं दिख रहा है? उसमें तो red blue दिखता है. This is a type of Doppler which is called as power Doppler, where you see the vessels as orange color. It is a Doppler which helps to detect even a low velocity blood flow. The ring of fire. If you see yolk sac, so I tell you that on ultrasound I see that there is a gestational sac, and in that gestational sac I see the yolk sac also. The yolk sac is a definitive sign of intrauterine pregnancy. It is a definitive sign of intrauterine pregnancy. A pseudo gestational sac will not have a yolk sac. Suppose if the USD is negative, you are not seeing anything on USD. Then what will you do next? Beta HCG. If the beta HCG is more than 1000, it's ectopic. If it is less, the next thing that I can do now is look at the doubling. The doubling of the beta HCG. Normally the doubling occurs in how much time? 48 hours. In 2 days, the beta HCG values double. So if the doubling is present, that means it's a normal pregnancy. If the doubling is absent, it is not doubled. That means it is ectopic, because in ectopic, the beta HCG values do not rise as much as the normal pregnancy. So the doubling time is increased. Remember, in ectopic, the beta HCG is comparatively low and the doubling time is also more. And if the beta HCG values are decreasing, 48 hours के बाद मैं देख रही हूँ कि ये पहले से कम हो गया, that means it's a failed pregnancy. Management of ectopic. If it's an unruptured ectopic, the fetal cardiac activity is absent, you can do an expected management or a medical management. If it's a ruptured ectopic has to be treated by surgery, surgical treatment. So unruptured, either you can do expectant, कि देखते हैं, या medical. Expectant management, you will do when the beta HCG is falling automatically on its own. The patient understands the risk and the beta HCG is less than 1500. You will do a medical management. The most common drug used here is methotrexate. When will you do the medical management? It should not be a live ectopic. The sac should be small sac, less than 3 centimeters. Beta HCG should be less than 5000. So beta HCG कम होना चाहिए, sac भी छोटा होना चाहिए. Then you will do the medical management. The other drugs that you can give in the sac are also KCl, potassium chloride, and actinomycin. Apart from methotrexate, KCl, actinomycin. Methotrexate is given systemically. The regimen is either you can give single dose or multiple dose. Single dose methotrexate. What is the dose of methotrexate given? 50 milligram per meter square, not kg. 50 milligram per meter square. And how is it given? Oral nahi, IM. Next dose is on day 7. Multiple wala is you give it on day 1, 3, 5, 7. Alternate. So 2, 4, 6, 8 में क्या देते हैं? Day 2, 4, 6, 8 में भी क्या देते हैं? Folinic acid to reduce the toxicity of methotrexate. So 2, 4, 6, 8 folinic, 1, 3, 5, 7 is methotrexate. What is the dose of methotrexate that you give here? Here in multiple, it is 1 milligram per kg. Right? And for single, it is 50 milligram per meter square. So remember that the relative contraindications for methotrexate are small sac or large sac? Large sac. Sac size more than 3 to 4 centimeters. Fetal cardiac activity present or absent? Present. Live में नहीं देंगे. Beta HCG high. More than 5000, you will not give methotrexate. An absolute contraindication for giving methotrexate is intrauterine pregnancy. In intrauterine pregnancy, we do not give methotrexate. USG sign we have seen, pseudogestational sac, ring of fire, most common site ampulla, most common rupture site is isthmus, most common risk factor is PID. Management can be conservative or surgical. Surgical is done when it is ruptured. Sac size is more, beta HCG is more, it's a live pregnancy. And whenever you are doing surgical management, you will have to also give NTD. How much is the dose of NTD? How much? 50 microgram, the dose of NTD. Up to 12 weeks, 50 microgram. More than 12 weeks, 300 microgram. The new guidelines say that सब में 300 microgram. In a ruptured ectopic, how will you know that the ectopic is ruptured? Either by the clinical sign. Ruptured मतलब अगर ectopic rupture होगा तो bleeding होगा, hemorrhage होगा तो shock होगा. That means blood pressure less than 90, suggestive of unstable. So complaints, features of shock, syncope are indirect telling you that it is a ruptured ectopic. On ultrasound, what will I see is because it is ruptured, the blood coming out. So I would see the fluid in the POD. Right? Blood anywhere, basically you will see fluid. Similar to fast sonography, where in blunt trauma, if you see fluid, it is blood. This blood can cause the shoulder pain. Why this shoulder pain? Because your blood होगा, Diaphragm को irritate करके there is the shoulder pain. Right. So remember, these are the clinical features. In rupture, you will have to stabilize the patient fast, and you'll have to do the surgery, laparotomy. The definitive surgery is, what is the definitive surgery for ectopic? पूरा ट्यूब ही निकाल दो. Salpingectomy. Ectomy means complete removal. But if the female is, no, I want to preserve this, do not remove the complete tube. If fertility needs to be preserved, then you can do salpingostomy. Stoma मतलब just the opening. तो ट्यूब में सिर्फ ओपनिंग करो और ectopic निकालो, that is salpingostomy. But the risk with salpingostomy is the ectopic removal might be incomplete, and therefore it is important to follow up after salpingostomy with beta HCG, and it should fall. Right, so after salpingostomy, it is important to follow up with beta HCG levels. What is a heterotopic pregnancy? Heterotopic, two different sites, that is intrauterine plus extrauterine. So will you give methotrexate in a heterotopic pregnancy? No, because it's intrauterine as well. So methotrexate contraindicated. So the treatment has to be surgical. The ectopic pregnancy criteria that we have, what is the criteria for abdominal ectopic? Name, study code. For cervical, Rubens. For ovarian, Spiegelberg. Right? Remember that for this has been asked even in your INICT AIMS exam. So again, INICT मतलब सब high-fi question नहीं, it can be fact-based one-liner questions. So Rubens is heard of Rubens cannula, which is used for cervical cannulation. Remember, Rubin is cervical. Spiegelberg is the sperm and the ova, so ovarian. Study code is a stud. Look at the stud having the abs, which is abdominal. So stud, abs, abdominal. Study code is abdominal. So Rubin, cervical. Spiegelberg, sperm, ovary, so ovarian. Study code is abs. Stud has abs, abdominal. नेक्स्ट टाइम तुम में से किसको फोटो देना हो तो दे देना, तुम्हारा लगा दूंगी. ठीक है, इफ एनी स्टड हियर. ठीक है, नेक्स्ट इज द ट्विन प्रेगनेंसी. ट्विन, लैम्बडा साइन, टी साइन. वेयर डू यू सी लैम्बडा, वेयर डू यू सी टी? लैम्बडा इज laddu and modi. Remember, the mnemonic for twin is laddu and modi. Laddu is, laddu का definition नहीं पूछ रही हूँ. laddu stands for, laddu is lambda, dc, da, dd. Laddu lambda is seen in dichorionic, diamniotic. Moti ji, the most famous, tea, the most famous chai wala in our country, the most famous tea. Remember, Modi is tea. What does Modi stand for? Monochorionic diamniotic. It is MCDA. Right? Monochorionic diamniotic. In which of these the separating membrane? What do you mean by diamniotic twin pregnancy? Matlab there are two amniotic sacs. Each fetus has its own amniotic sac. That is diamniotic. So a diamniotic pregnancy will have this separating membrane. Now this diamniotic could be monochorionic or it could be dichorionic. Now in which of these the separating membrane will be thick? Dichorionic, diamniotic. Right? So remember that a thick membrane will be seen with the lambda sign wala, which is also called twin peak, that is DC, DA. So lambda sign is like this, the separating membrane in between, and the two are going away like this with a triangle in between. That's the lambda sign. While in the T sign, you have the separating membrane and a single chorion. So this is monochorionic diamniotic. Separating membrane matlab diamniotic. So if you see the lambda sign, that means the separation had occurred at what days? Less than 3, 3 to 8, 8 to 13, more than 13. कितने days पे हुआ था zygote बनने के बाद? Less than 3 days. So remember, this is important. Separation is seen at what duration in what twin pregnancy. This is basically the law of life. If you spend a lot of time with someone, the separation is easy or is it difficult? Difficult. जितना ज़्यादा time spend करोगे, उतना attach हो जाओगे, separation मुश्किल होगा. तो separation करना है तो जल्दी कर लो. You'll have your independent life. So remember that जितना late separation करोगे, उतना attachment बढ़ेगा. So if it is late, सबसे आखिरी, इतना close, conjoined. तो conjoined is मतलब सबसे आखिरी में. अगर सबसे अर्ली सेपरेशन डेज है, दैट इज विद इन 3 days, भाई जल्दी सेपरेट हो जाओ. तो इट इज कोरियन भी अलग, एमनियन भी अलग, डाइकोरियोनिक, डाइएमनियोटिक. So remember that the chorion is like the house and the amnion is the room जिसमें the fetus is staying. So fetus staying, first covering is the amnion और बाहर वाला is the chorion. So when I say the separation is maximum, the separation is maximum when the separation is early. They are having more independent life. तो जल्दी separate कर दिया तो दोनों के घर भी अलग हो जाएंगे. So it will become dichorionic. When the घर अलग है तो पॉसिबल है क्या कि रूम एक होगा, दो घर में और एक ही रूम में रहेंगे, ऐसा है क्या? नहीं होगा. Obviously when there are दो अलग घर हैं तो रूम भी अलग अलग है. So always a dichorionic has to be a diamniotic. You cannot have a pregnancy which is dichorionic and monoamniotic. When the separation is between 3 to 8 days, the closeness is increasing, right? फिर क्या होगा? They be like एक घर में रहते हैं लेकिन अलग अलग रूम में रहते हैं. So that is monochorionic, diamniotic. Or late separation 8 to 13, they are like इतना भी दूर नहीं रह सकते हम, एक ही घर में एक ही रूम में. So this is monochorionic, monoamniotic. उससे भी लेट किया तो अभी रूम भी एक है, बेड भी एक है, conjoined. Right, so remember that the earlier the separation, घर अलग अलग होगा, फिर घर एक होते जाएगा, फिर रूम एक होते जाएगा, फिर बेड भी एक हो जाएगा. Maximum complications out of DCDA, MCDA, MCMA is monochorionic, monoamniotic. जितना attachment, जितना closeness ज्यादा, उतने ज्यादा complications. Right, so MCMA has maximum complications like twin to twin transfusion syndrome is MCMA. Bishop score, Apgar score. Bishop score is used for looking at the favorability for induction, the cervical induction. So favorable है कि नहीं induce करने के लिए, that is what the Bishop score is used for. If the score is less or the score is more, when is it called favorable? The score has to be more than 6. So you have the modified Bishop score. What is modified? What was the original Bishop score? Remember, Bishop score is for induction. मतलब डिलीवरी के टाइम पे whenever डिलीवरी होने वाली है तो हम किसको बुलाते हैं? गायनेकोलॉजिस्ट, ऑब्स्टेट्रिशियन तो है ही, बट साथ में किसको बुलाना पड़ता है? पीडियाट्रिशियन को. नियोनेटोलॉजिस्ट, पीडियाट्रिशियन. So remember the mnemonic for the Bishop score is call peds. Call peds. So the components of Bishop score are call, beats, that is consistency, position, effacement, dilatation, station. So the factors that you see here are related to the cervix. Cervix consistency, soft है, hard है, anterior है, posterior है, dilated है कि नहीं, and the last one is related to the fetal head. Is there anything related to the maternal pelvis? नहीं. Nothing related to maternal pelvis here. In the modified Bishop score, what has been modified? Effacement is effaced. What do you mean by cervical effacement happening? Effacement मतलब cervix short होते जाता है. Effacement. So in the modified, the effacement is effaced. It is gone. It is replaced by cervical length. We measure the length, not the percentage of effacement. So here in the modified, you have the cervical length. What is going to be favorable, a soft cervix or a hard cervix? Soft. That will be given higher score. Soft cervix. Anterior cervix, posterior. Anterior cervix. Cervix facing anterior towards the vagina, that is favorable. Station. Fetal head station. Fetal head नीचे होना चाहिए कि ऊपर होना चाहिए? नीचे. What is the नीचे वाला position called as? +1, +2, that is below the spines. The cervix should be dilated. The length should be less or the length should be more. What happens? The length decreases. Right? The length decreases. So that is the Bishop score. Remember, effacement is effaced. It is replaced by length. In the Apgar score, which is done in the newborn, basically to see that everything is good in the newborn, what all systems are we checking here? Is it CNS, CVS, RS? What are we checking? All the three. CNS, CVS, RS. Right? So what are the components of the Apgar score? Apgar is the mnemonic. A for appearance. कैसा दिख रहा है बेबी? पिंक है कि ब्लू है? P for pulse, heart rate. G is grimase. A is activity. R is respiration. So you're looking at the CVS, the pulse, cyanosis वगैरह. You're looking at the CNS, the activity, and the respiration. So everything is being tested. Respiration, remember, is not the respiratory rate. Are you calculating the rate here? No. What do you see in Apgar is only the effort, the respiratory effort. So is there a strong cry on birth, or is there slow irregular breathing, or it is apnea? So what are the scoring in Apgar? What is the minimum and the maximum? So you have Apgar, APGAR, 5 components. The score is given 0, 1, 2. So minimum will be 0, maximum will be 10. Higher the score, better or worse? Better. Right, so the 0, 1, 2 score that we are giving, 2 is basically for everything normal, 0 is absent. So बीच का जो है anything abnormal is 1. So 2 मतलब normal. What is the cutoff to say that the heart rate is normal? Should be given a score of 2 or a score of 1. What is the cutoff for that? 100. More than 100 is normal. Right, that's why you see that in NRP, the neonatal resuscitation, when are you starting that? Breath, ventilation, heart rate less than 100. So 100 is the cutoff. Grimase is a score of 1. Grimase matlab a weak cry when stimulated, and strong crying, coughing is a score of 2. That is normal. Weak cry, grimase is a score of 1. Pink baby will be given a score of 2. Pink is normal, score of 2. Only the peripheral cyanosis is given a score of 1. Peripheral cyanosis is something that we are not as worried as much as central cyanosis. Right, so this is आपका score. Coming to amniotic fluid, right? So within the amniotic sac, you have the fluid. कहाँ से आता है ये fluid? सबसे पहले the amniotic fluid, what contributes to the amniotic fluid production? The maternal transudate. Right, from the placenta, the transudate happening, that is the initial one. Then comes the transudate from the fetus skin. And last में आता है the major contribution when the kidneys, ureter, bladder is formed. Right, the organs are now formed. So now that will be after 20 weeks, fetal urine. Fetal urine. What is the first system to develop in the fetus? CVS, RS, CNS, kidney. क्या first develop होता है? CVS. सबसे पहले fetal cardiac activity देखते हो ना, right? That comes the first. So fetal urine is the major contributor after 20 weeks. Does amniotic fluid have any nutritional role? नहीं. ये urine है, सिर्फ पानी है और कुछ नहीं है. So no nutritional role. If there is, what happens? How's the circulation of amniotic fluid? So fetal urine producing the amniotic fluid. This amniotic fluid is swallowed by the baby, and that is how it goes down. Basically, that's how the circulation is happening. If there is a swallowing problem, what will happen to the amniotic fluid? Increase or decrease? Increase. क्योंकि swallow नहीं कर रहा है, तो fluid बाहर रहेगा. It will increase. It will lead to polyhydramnios. Example being cleft palate, esophageal atresia, duodenal atresia. So anything interfering with that GIT is going to be increased AFI. On the other hand, decreased AFI will be a problem in renal, क्योंकि यूरिन नहीं बनेगा, AFI कम होगा. Right, so oligo will be seen when there's a renal or the urinary outflow obstruction. When do you call it oligohydramnios and polyhydramnios? The single deep pocket that we measure on ultrasound, if it is less than 2 centimeter, the total index of AFI in the 4 quadrants less than 5. Here, the deepest pocket being more than 8 centimeters or the AFI more than 25. So AFI less than 5, AFI more than 25, or the total quantity here more than 2 liters. If there's a poly, what do I need to do? Reduce the amniotic fluid. So what is the management? Amnio reduction. Logical. Amnio reduction is the treatment for polyhydramnios. So in the recent NEET PG exam, the question was polyhydramnios mein the fetal part will be better felt or not felt? Not felt. Right? Less feel होंगे क्योंकि इतना fluid है उसके अंदर fetus है. So duodenal atresia will be oligo या poly? Poly. Following problem है. Renal agenesis will be oligo or poly? Oligo. There is something called as Potter sequence. Renal agenesis, Potter sequence. Remember, oligo is what is associated with clubfoot. Because if there's oligo, there's no fluid. What will happen is, jagah hi nahi hai, there's nothing for that fetus to move the limbs. The foot will go into clubbed foot, CTEV. So CTEV is associated with oligo. Maternal diabetes. Oligo ki poly? Poly. Because maternal diabetes hoga, what will happen to the fetus? Hyperglycemia, hypoglycemia. Hyper. Whenever there's hyperglycemia, diabetes, what is the clinical feature? Polyuria. So mother mein polyuria, fetus mein polyuria. So there will be fetal hyperglycemia leading to fetal polyuria, increasing the fluid. Poly. Isoimmunization, RH incompatibility. Again, it is poly. Anencephaly, poly, CSF going out, contributing to amniotic fluid. And uteroplacental insufficiency, oligo. And a uteroplacental insufficiency, the transutate, the pressure is decreasing, transudation decreasing, oligo. Example of that is preeclampsia. Please remember, preeclampsia is oligo, maternal diabetes, RH incompatibility is poly. Maximum amniotic fluid is seen at 34 weeks. If the amniotic fluid, meconium stained amniotic fluid is what color? Green color. Right? So जब deliver करते हैं, अगर meconium stained है, it is green. Meconium stained is green color. RH incompatibility will have what amniotic fluid color? Golden yellow. Why? In RH incompatibility, basically there is hemolysis. Whenever hemolysis is there, the bilirubin increases. Bilirubin is going to give the yellow color. RH incompatibility is what hypersensitivity basically happening here? Type 2, antibody mediated. Right, so that is about amniotic fluid. Going to dual, triple, quadruple marker test. When do you do the dual? First trimester. When do you do the triple and the quadruple? Both of them in second trimester. थर्ड ट्राइमेस्टर में कोई मार्कर करके कोई सेंस नहीं है, राइट? इट इज फर्स्ट एंड सेकंड. So you start with dual, triple and quadruple is second. So in the first trimester dual, what are the two markers? Beta and papa. सबसे पहले आएगा बेटा पप्पा, बीटा HCG, पैपिड. ट्रिपल में what is not there? Inhibin. Remember, in triple, inhibin is inhibited. Inhibin is not in triple. Inhibin is inhibited in triple. Inhibin is included in quadruple. Even in that, which inhibin? A. A is allowed, B is banned. The estrogen that you measure in the triple or quadruple test is estrone, estradiol or estriol. It is triol. Remember now, the family is basically of three: the mother, the father and the baby. So pregnancy में the predominant estrogen is estriol, not estradiol. It is conjugated, unconjugated. UE3, that is unconjugated estriol. What we measure is unconjugated estriol, not conjugated. In Downs, what increases? High is high. In Downs, high is high, HCG and inhibin are high. Rest everything is decreased, including AFP. Did we see AFP levels? Where do they increase? Neural tube defect. Where else? Abdominal wall defect. Any body wall defect. Where did we see that? When we were seeing alpha fetoprotein as tumor marker. Tumor marker for HCC. Right? The yolk sac tumor. So in neural tube defects, what will you see? What is increasing? AFP. AFP increases in body wall defects. HCG will be normal, estriol will be normal. In Downs, HCG is high. In Edwards, ED, everything decreases. Edward, everything decreases. Biophysical profile, basically to look at the fetal well-being. You know, whether the fetus में सब ठीक है, there's no hypoxia, everything is good. So to see the fetal well-being, you have NST, you have CTG, cardiotopography. What is the difference in between the two? NST is done antepartum. And cardiotocography is done intrapartum. Please understand the terms. So when I say it is cardiotocography, what am I doing the graph of? Cardio, FHR and toco. What is toco? Uterine contraction. Tocolytic, breaking the contraction. When does the uterine contract? In labor. Right? So cardiotocography is when the female is in labor, intrapartum. Antepartum mein, it is just the fetal heart rate, that is non-stress test. The uterus is not in under stress of contraction here. So non-stress test is just the FHR. And what is the entire biophysical profile? What are the components in the entire biophysical profile? Batman. For biophysical profile is Batman. What is the Batman? Basically, you look for fetal, breathing, amniotic fluid, tone, movement and NST. ये वाले एक का कुछ नहीं है. There are 5 parameters: breathing, amniotic fluid, tone, movement, NST. That is FHR. NST basically is FHR. Biophysical profile, this पूरा 5 चीजें जो देखना है, you do have to do it over a period of 30 minutes. पूरा आधा घंटा देखना पड़ता है कि बच्चा कैसे मूव कर रहा है, मूवमेंट है नहीं है, ब्रीदिंग कैसा है, FHR कैसा है, right? So it takes like 30 minutes. So what have we modified it into? A shorter version. What is a modified biophysical profile? Which is quicker. It is fetal heart rate and the AFI. राइट. तो अगर आपको मूवमेंट देखना है बेबी का तो अल्ट्रासाउंड में देखना पड़ेगा. तो भी रेडियोलॉजिस्ट सेड कि हम आधा घंटा नहीं देखेंगे, इतना टाइम नहीं है. वी विल जस्ट डू द AFI फॉर यू गाइस. यू डू द FHR, वी विल डू द AFI. तो हमने OBGYN वालों को बोला तुम FHR देख लो, हम सिर्फ AFI मेजर करके दे देंगे, क्योंकि AFI मेजर करना 2 मिनट का काम है. सिर्फ बस फ्लूइड देखना और बताना है. यू डोंट हैव टू वेट फॉर द बेबी टू मूव एंड एवरीथिंग. So remember, it is a quicker version basically, just the AFI and the fetal heart rate. But this is not the reason. Why do we have a modified? Why are these the components? These are the components because FHR is a marker of acute stress. कोई भी stress होगा baby में, the first thing that will change in the body is heart rate. AFI is a marker of chronic stress. The amniotic fluid is decreased. एक दिन में नहीं होगा. There's something which is happening chronically. So that's a marker of chronic stress. So basically modified tells you both the acute stress and the chronic stress. So very important, in modified you have the FHR and the AFI. When do you call it a reactive FHR, a reactive NST? कितने episodes of acceleration होने चाहिए? 2 episodes of acceleration. Minimum 2 episodes of acceleration. The acceleration should be how much? 15. The heart rate should increase by 15 and it should last for at least 15 seconds. Remember, it is 15 beats per minute heart rate increasing, lasting for at least 15 seconds. There should be 2 episodes in those 30 minutes. So this is your difference between NST, CTG, biophysical profile, modified biophysical profile, and acceleration. अगर नहीं दिख रहा है, when do you call it bradycardia in the fetus? Heart rate less than 110. Deceleration, that means the heart rate going down rather than acceleration. You are seeing deceleration. What are the types of deceleration? Early, late, variable. Where do you see early deceleration? Head compression. Late is placental insufficiency and variable is cord compression. Important? Right, so remember that the mnemonic for your deceleration is if we see deceleration, we should immediately help the patient. So remember, if we see, then help. So what is VC? Variable chord. Help, HE. Head compression, early. Late, placental. VC, help. Help was also the mnemonic for efficacy, potency. Height efficacy, left potency. Right, so remember that it is help and VC. Chord compression will give variable deceleration. What are we doing here? NST है कि CTG है? CTG. Why? CTG में basically यहाँ पे will be a band where you ask the female कि जब भी contraction feel हो इसको press करना. So basically this is uterine contraction. Contraction is CTG. This graph is CTG or NST. You are seeing the fetal heart rate being demonstrated and you are seeing the contractions also being there. So this is going to be CTG. CTG will have both. So in CTG, what do you see is when the contraction is occurring, is there a deceleration? The relation of the deceleration to the contraction. If it is uterine contraction peak and the deceleration maximum depth, this is called as what deceleration? Early. Contraction खत्म हो गया, उसके बाद ही deceleration आ रहा है. This is called late. Deceleration कभी भी आ रहा है, then it's going to be variable. Right, so coinciding is early. That means what will be the cause here? Head compression. Late will be placental. In your biophysical profile that you had the 5 parameters Batman, remember the scoring is given as 0, 1, 2. It is 0 and 2. It is just 0 and 2. Normal is 2. Abnormal is 0. So can you have a biophysical score of 7? No. It has to be even number. Right? So as an intern अगर बोला गया कि देख लो biophysical profile score तो at least odd number तो मत ही बोलना. Blood pressure में तो हम झूठ बोलते ही हैं, इसमें odd number मत बोलना. Right? So remember, it's always an even number. The lower the score, the bad it is. Less than 6, you have to terminate. Score less than 6, terminate. Molar pregnancy. What is molar pregnancy basically? Moles. Molar pregnancy is molar pregnancy. What happens in molar pregnancy? What are the moles? Basically the cystic spaces which are developing, which are called as basically hydropic villi. So your gestational trophoblastic disease is divided into molar, non-molar. Molar matlab the villi are present. Non-molar matlab the villi are absent. So in the gestational trophoblastic disease, the molar one, you have the partial molar and the complete molar pregnancy. Partial molar pregnancy, complete molar pregnancy, basically which is benign. And if this becomes invasive molar pregnancy, then this is malignant. But remember, this invasive molar pregnancy will not have metastasis. The difference between invasive molar and choriocarcinoma is choriocarcinoma will have metastasis. Invasive molar is like locally invasive. It is not metastasized. No metastasis. Partial and complete. Which one has that triploidy? Partial. Remember, partial is RTI, TRI. It's a triploid. Partial मतलब सिर्फ partial molar है but बाकी normal है, मतलब fetal parts present. Complete molar मतलब सिर्फ molar है, the fetal parts are present or absent? Absent. So which one will have more levels of HCG, partial or complete? इसमें सिर्फ molar है, there are no fetal parts. Complete. So more HCG levels in complete. The more the HCG levels, does HCG stimulate the ovaries? Yes. Patient of IVF, हम देते हैं HCG, HMG injection. It stimulates the ovary. If it stimulates the ovary, what will you see in the ovary? बड़े follicles, cysts. What are these cysts called as? Theca lutein cysts. Remember that theca lutein cysts are seen in molar pregnancy. Where else can I see theca lutein cysts? Where else the beta HCG is high? Twin pregnancy. Twins, the beta HCG is high. There can be theca lutein cysts there as well. More risk of turning into the GTN, the gestational trophoblastic neoplasia, is with complete or partial? Complete. So complete में HCG ज़्यादा, theca lutein cyst, GTN का risk ज़्यादा. When I do the ultrasound, if I see this snowstorm appearance, it's a complete or partial? Complete molar. Snowstorm means there are no fetal parts. It is just the cystic appearance that you would see, like you are seeing here on this ultrasound. Just the black fluid filled cyst is what you are seeing in the entire endometrium. There is no fetal part. So snowstorm is complete molar pregnancy. The clinical features that you see in molar pregnancy is basically because of the high beta HCG. The beta HCG is high. Beta HCG high होगा, vomiting ज़्यादा होगा, hyperemesis gravidarum. The uterus size will be more because it is all hydropic villi increasing the uterine size. The patient can present with PV bleed in the first trimester itself. From the starting itself, there can be bleeding. Basically, those vesicles, the moles coming out, the patient comes with history of grape-like vesicles coming out per vagina. There can be thyrotoxicosis. Why? Because HCG mimics TSH. What HCG? Alpha ki beta. What mimics TSH? Alpha HCG. Remember, therefore, in pregnancy, we test alpha HCG or beta HCG. Beta HCG. क्योंकि ये specific है. HCG mimics TSH, so it will TSH जैसे thyroid को stimulate करेगा, thyrotoxicosis होगा. So important feature thyrotoxicosis. Pre-eclampsia हो सकता है because there are anti-angiogenic factors which are released. So all these features are there. You test the beta HCG levels or you do the UPT test. Is it possible that a patient of molar pregnancy with high beta HCG can have UPT negative? Yes. UPT can be false negative. Why? Because UPT is only for a specific range of beta HCG. उसके ऊपर चले गया तो वो negative हो जाएगा. So it is only for a specific range. So it can actually be false negative. How will you manage a molar pregnancy? Because it can turn invasive. So we always have to remove it. Suction, evacuation, irrespective of the gestational age, irrespective of the uterine size. It is suction, evacuation. इसको तो मैंने निकाल दिया suction evacuation करके. How about the theca lutein cyst in the ovary? What should I do for them? Theca lutein cyst, majority of the times have spontaneous resolution. Why? Because when I do the suction evacuation, the HCG is gone, so the stimulation is gone, so the theca lutein cyst will also go. So they should resolve spontaneously in 2 months after suction evacuation. Within 2 months of suction evacuation, they should disappear. If they do not disappear, they are persistent. That means then what am I thinking of? Neoplasia. Right? If it is not decreasing, that means it is now a GTN. Can the theca lutein cyst undergo twisting? Yes. If it undergoes twisting, तो क्या करोगे? कुछ नहीं, untwist कर दो. Will you do an oophorectomy? Not. Only if there is extensive necrosis and hemorrhage, then only you will do oophorectomy. Post suction evacuation, patient wants contraception. What should not be given? IUD. क्योंकि soft uterus है, IUD दोगे, perforation हो सकता है. So remember that IUD is contraindicated. The features telling me that this has become a neoplasia, it is now malignant, is beta HCG is increased, it is high even after suction evacuation. कम ही नहीं हो रहा है beta HCG. So after suction evacuation, is it important to measure, to monitor the beta HCG levels? Yes. So that's why you need to monitor beta HCG after evacuation. And you need to compare with the baseline. कि कम हो रहा है कि नहीं हो रहा है. So within 48 hours of suction evacuation, you take the baseline levels and you monitor it weekly till it becomes negative. And then you do it monthly for how much duration? 6 months? Yeah, 12 months. If it's just a molar pregnancy, you do it for 6 months. If it is malignant, like choriocarcinoma वगैरह, then you do it for 12 months. The features suggestive of malignancy are, of course, we said persistent or increased beta HCG. The other features are theca lutein cyst not disappearing. The increase, they are increasing in size or they are not disappearing. Remember, not the increase in number. This is your previous I9CT exam question. Increase in number is not a marker of malignancy. Increase in size is. Third, if there is metastasis, what are the findings of metastasis? Clinical finding that I can see? Suburethral nodule. If there is a suburethral nodule, basically it is suggestive of vaginal metastasis. Suburethral nodule is the finding of vaginal mets. Other mets that can occur is in the lungs, cannonball metastasis. Previous INI exam question again. If you see the cannonball metastasis, what stage cancer this is? 3. Remember, this is not stage 4. The lung metastasis comes in stage 3. So stage 1 is confined to uterus. Uterus में है. Stage 2 मतलब बस आजू बाजू में जा रहा है. Adnexa vagina. And stage 3 is lungs. Baki metastasis is 4. The treatment for your malignant is, what drug can you give here? Again, methotrexate. It could be a single drug regimen or a multi-drug regimen like, what regimen is it? Imaco regimen. Imaco regimen is for your malignant molar. So whether I should give single drug methotrexate or the Imaco depends on the risk. The WHO risk score, there's something called as WHO risk score. If it is up to 6, it is low risk, give methotrexate. If it is more than 6, high risk, give Imaco. Right, so these are all the points for your molar pregnancy. Very, very important. Remember, increased beta HCG, increased uterine size, hyperemesis brevidarum, thecal lutein cyst. Suburethral nodule is a finding of metastasis. Vaginal metastasis, stage 2. Lung metastasis is stage 3. Right, it is stage 3. After structural evacuation, you need to monitor the beta HCG. It should fall. So that is molar. Coming to antepartum hemorrhage. Antepartum hemorrhage is defined as hemorrhage occurring after 28 weeks. In India, basically we use the timeline of after 28 weeks. According to RCOG criteria, it is after 24 weeks of pregnancy. So after 28 weeks, that is the period of viability. The hemorrhage, if it is occurring, what are the causes that you think of? What are the various causes that you think of? Placenta previa, abruptio, vasa previa, or a uterine rupture. So remember that the causes that we are thinking here is placenta previa. Either it is placenta previa, abruptio, vasa previa, or uterine rupture. These are the 4 important causes that we should consider. How will we differentiate this? Is placenta previa is painless. It's a painless bleeding which occurs. The female comes with, woke up in the morning and the female finds herself in a gush of blood. So it is painless. Overnight bleeding. मालूम ही नहीं पड़ा क्योंकि painless है. While abruptio, what do you mean by abruptio? What is abrupt? Abrupt मतलब sudden. Abruptio placenta means the sudden separation of placenta. The placenta is separated. That is what is abruptio placenta. When the placenta is separated, what will you see? What will happen? There's going to be hemorrhage. There's going to be pain. So this is painful and tender. Now this hemorrhage which is occurring because of the separation separation of the placenta, it could be concealed, कि अंदर ही अंदर बस bleed हो रहा है, or it could be a revealed hemorrhage. That means it can come out through the cervical os. Remember, it could be concealed or it could be a revealed hemorrhage. When it's a concealed hemorrhage, obviously what will happen to the uterine size? Increase. So in abruptio, you will have the uterine size which is more than the gestational period, the weeks. While in placenta previa, the uterus size is equal to the period of gestation. These are all the important features that help you differentiate. So in concealed hemorrhage, what can happen is अंदर hemorrhage हो रहा है. Then there is something called as covalar uterus, a uterus which is colored because of all the hemorrhage, the bleeding, uterine apoplexy. This occurs in concealed hemorrhage. So if you see covalar uterus, when you are opening up the patient, you are seeing here a covalar uterus है ये. Will you remove the uterus? कि hysterectomy कर दो? नहीं, it's not an indication for hysterectomy. The other finding that can be mentioned in question for abruptio is DIC. Because this abruptio also leads to the release of this thromboplastin, which can lead to DIC. Other important condition that can lead to DIC in the mother, one is abruptio, and second is when else the thromboplastin is released? When there is IUFT. Intrauterine fetal death is another condition which can cause DIC in the mother. What is vasa previa? Vasa previa मतलब bleeding. जैसे placenta previa is bleeding from the placenta, the low lying placenta. Vasa previa is bleeding from the vessel. The vessel is bleeding. Which vessel? The fetal. So the blood that is coming out in vasa previa is what blood? Fetal blood. Why in placenta previa it is not the fetal blood? So is there any test which can tell me कि ये maternal blood है कि ये fetal blood है? Apt test. So apt test basically is suggestive of fetal blood. In which condition you see vasa previa? कब होगा vasa previa? When there is vessel, if this is the cervical os, there is vessel over the os. That is what placenta? Filamentous placenta. Remember vasa previa, filamentous placenta. And because it's a fetal bleed, what will you see here? Fetal distress. Fetal bleed will lead to fetal distress. While uterine rupture, when does the uterus rupture? When it's not strong enough, the muscle is not strong enough, because now instead of the muscle there's a scar. So history of previous LSTS, that means there's a scar in the uterus and that is why it ruptures. So classical history in uterine rupture will be history of previous LSTS, because the uterus has ruptured, the contraction stop. The fetal parts are well felt or not felt. क्योंकि ये rupture हो गया, fetus बाहर आ गया, so it is well felt. Why it is not well felt in polyhydramnios? जो हमने देखा polyhydramnios. So well felt fetal parts, contraction has stopped, previous LSTS is uterine rupture. What is placenta previa? It's a low-lying placenta. So the classification here, you have low-lying, marginal, partial and complete. When I say it's a low-lying placenta, that means it is within 2 centimeters of the os. So look at this one. If you're given a diagram which comes as an image-based question, this is the lower edge of the placenta, which is not covering the cervix here. That means it is just a low-lying placenta within 2 centimeters. Marginal placenta means touching the cervix, touching the margin of the cervix. Marginal just touches. Partial or incomplete, matlab it is not going to the other side. If it is going to the other side, then it is complete. Complete matlab aise pura. Complete placenta previa, also called as central, partial is incomplete. So remember that here the history is sudden, painless bleeding, which occurs generally at night during sleep. The uterus corresponds to period of gestation versus abruptio, the uterine size is more because there's concealed hemorrhage. So in any case of APH, antepartum hemorrhage, because placenta previa is a possibility, will you do a PV? Because placenta previa, low-lying placenta, you don't want to do a PV because the placenta is low-lying. So remember that first you will have to rule out placenta previa. So remember the rule is no PV until you prove that there is no PP, that is placenta previa. No PV until no PP. And how do I prove that there is no PP? What investigation tells me कि uterus कहाँ, ये placenta कहाँ पे है? किसमें दिखेगा? USG. So first we will have to do USG. Right? पहले USG करके you will have to rule out placenta previa, whether the placenta is low-lying or not. Placenta can be better seen on TVS. So first is transabdominal, then is transvaginal. Placenta previa, remember, is the most common cause for transverse life of fetus. How do you manage placenta previa is LSCS if the female is in labor or gestation is more than 37 weeks. But अगर less than 34 weeks है, conservative management करना पड़ेगा. What is the regimen called as? McAfee. Remember, McAfee regimen is for placenta previa or abruption. Cafe में coffee PP. Cafe is PP. McAfee is PP. So conservative in hospital management if it is less than 34. In abruptio, there is chance of DIC, shock, fetal distress. If any of this is present, you'll have to do a delivery. Should you give tocolytics? No tocolytics. If it's a stable patient, conservative in hospital management. Remember, the page classification is used for abruptio, placenta previa. Abruptio. Page classification is for abruptio. Remember it as tone, page, and a tone placenta. Page is tone, placenta is tone. Tone placenta matlab abruptio. What can cause this abruptio? The placental tearing, the placental separation, trauma. So history of trauma is commonly given in a case of abruptio. And remember that preeclampsia is a high risk factor for abruptio. It is not protective, it is high risk factor for abruptio. Right, so this is what helps you differentiate the causes of antepartum hemorrhage. McAfee regimen is, McAfee is for Cafe PP. Page classification is for abruptio placenta, tone page. Coming to obstetric maneuvers. So obstetric maneuvers में the first maneuvers that we are seeing here are the maneuvers for shoulder dystocia. क्या है? क्या दिख रहा है यहाँ? Breech. What is coming at the last? The head. So basically this we are seeing for breech. So the maneuvers for breech. In the breech, the head comes the last. In the breech, the maneuver which is used for popliteal fossa, leg निकालने के लिए popliteal fossa वाला. Remember, for popliteal it is pinard. You will see the finger in the popliteal fossa. What is the maneuver for the arm? Where you are seeing the arm यहाँ पे, the arm is extended. For the extended arm, it is what maneuver? Love stitch. We show the love with the arm, hugging with the arm, and we also show the love by chocolate, right? So that's the chocolate. कहाँ देखा था ये? Leventhal. Chocolate is for hemophilus, right? Please remember that love stitch is arm delivery, arm को निकालने. Coming to the head. So in the head, if you see here, यहाँ पे pubic symphysis, pubic के यहाँ क्या है? Anteriorly chin है कि occiput है? Occiput, right? इधर occiput, इधर occiput. This is the only one where you're seeing the chin is occiput पीछे है, chin आगे है. So what is the one which you will use for chin to pubis? Chin to pubis is Prague maneuver. Chin to pubis is Prague. बाकी हेड के लिए क्या क्या मैन्यूवर्स हैं? So you have the maneuvers Vigard, Martin, and MSV. Right, this is the MSV. So how do you identify this is Vigard, Martin or MSV maneuver? Vigard, Martin is how many words? 2 words. MSV is how many? 3. Jitna words, utne haath. So Vigard, Martin, you are seeing one hand and second hand. Here you are seeing how many hands? 1, 2, 3. So Vigard, Martin, 2 words, 2 hands. MSV, 3 words, 3 hands. What do you do in MSV? MSV में क्या क्या कर रहे हो with the 3 hands? Malar flexion, shoulder flexion, and fundal pressure. So basically remember MSV, M for malar flexion, S for shoulder traction, with V for width, with the fundal. Vigard Martin में क्या नहीं है? Out of the 3, shoulder traction नहीं है. Vigard Martin with the fundal, malar is there, S is not there, shoulder is not there. So 2 hands, Vigard Martin, 3 hands, MSV. And where? In this after coming head of the breech सब कुछ बाद आ गया, सिर्फ head है अभी. What do we do if you are just holding the baby with the feet and you are just holding the baby, curving it and taking it out, telling the baby that you do not need any malar flexion, shoulder flexion, you are a marshal, you can do it. बस एक simple maneuver, बस पैर से पकड़ के बाहर लेके आ जाओ, that is marshal, like a marshal. So Burns marshal, there is nothing there, no malar, no shoulder. You just curve the baby and get the baby out. If the question is what is the best for after coming head in the breech? Piper's faucet. This Piper's faucet which is the best. So what will be the answer here? All of the following are used in breech except, sorry, Zavanelli. MSV देखा, Prague देखा, chin to pubis, Lobset देखा, arm, Zavanelli नहीं देखा. So even if you don't know Zavanelli कहाँ है, कहाँ नहीं है, किसके लिए, but ये तो पता है कि ये breech के लिए है. So you don't have to break your heads on the rest, the option that you don't know. Ruling out the option, coming to the answer is what you need here. So Zavanelli is used for shoulder distortion. Zavanelli is Zava Zava, say Shava Shava. That is shoulder. Zavanelli is Shava Shava. So what do you have for shoulder dystocia? What are the maneuvers? Shoulder dystocia basically is your normal, the head coming first, but the shoulder is stuck. So you try to get the shoulder out. So when you are trying to get the shoulder out, so you have the maneuvers that is Rubin and Woodcock screw. So how will I decide it is Rubin or it is Woodcock screw? Is in Rubin जो शोल्डर रुका हुआ शोल्डर है हम उसको रोटेट करते हैं पहले. So look at the hand, the shoulder that we are rotating is the one which is impacted. Impacted pubic bone के वहां जो है रुका हुआ उसको टर्न कर रहे हैं. Woodcock screw में the hand is here, pubic वाला नहीं, it is unimpacted. So remember Woodcock screw is W and U coming together. So it is unimpacted. Rubens is रुका हुआ. Rubens is रुका हुआ, Woodcock screw unimpacted. This is very, very important and the most important maneuver here, Meg Roberts. Meg Roberts, RO is used in SO, SHO, shoulder. Roberts is for shoulder dystocia, not for breech. What are we doing in McRoberts is, you ask the female to flex, take the thighs on the tummy, abduct, and then the pressure is given. So in McRoberts, remember that because of this, what is the complication that can occur? Meralgia paresthetica is MR McRoberts. McRoberts, meralgia paresthetica, which is what nerve? Lateral cutaneous nerve of thigh. The lateral cutaneous nerve of thigh gets compressed in this position. There can be meralgia paresthetica. This one, ये breech नहीं है, but shoulder stuck है. We have tried to remove the shoulder out, but हो नहीं रहा है. So what is the option that we have? Baby को वापस भेज दो, LSCS कर दो. So Zava Nelly is, you tell the baby, Java Java, अंदर जाओ, हम आपको यहाँ से निकालेंगे. Right, it is Java Java. And the baby is like, Shava Shava. Right, so it is for shoulder dystocia. Java Java, Java Java, Shava Shava. तो यहाँ पे why this is not Rubens or Woodcock's rule? इमेज बेस में कैसे मालूम पड़ेगा? हम यहाँ पे शोल्डर को घुमा रहे हैं क्या? नहीं, किसको घुमा रहे हैं? हेड. तो जो हेड का रोटेशन हुआ था उसको वापस घुमा के वी आर सेंडिंग बैक. इट इज द हेड व्हिच इज रोटेटेड हियर, नॉट द शोल्डर. This maneuver, right, Ajibu-Garib maneuver, basically to get the shoulder out. The female goes on all four. This is Gaskin. It's like Gaskin is gas passing. It's like the female is passing the gas. Or the female is gasping for breath. It's like gasping in all four position, all the four down. There's Gaskin. Right, so this is how you identify the maneuvers, the breech, the shoulder dystocia, and which is the maneuver that you use in all normal vaginal deliveries. What's the maneuver? Ritgens. Ritgen maneuvers has been asked in one of the recent exams. Ritgen maneuver is what is Ritgen is general use maneuver in normal vaginal delivery. So in Ritgens, why do we do the Ritgens maneuver in normal vaginal deliveries? To prevent the perineal tear. So it's not a breech delivery. It is not shoulder dystocia. Basically, you would see one hand posterior and one hand holding the head of the baby. So with the posterior, we are trying to do some extension, and with the upper hand, we are trying to make sure कि बहुत ज़्यादा एक्सटेंशन भी नहीं है और बहुत फोर्स से हेड बाहर नहीं आ रहा है. So it is basically for controlled delivery of the head. ऐसा नहीं है कि डिलीवरी हो रहा है तो बस फटाफट आ गया. With any pressure it can come. There has to be controlled delivery to prevent the perineal tear. So this is Ritgens, generally used in all normal vaginal deliveries to prevent the perineal tear. The next maneuvers, the Lippold maneuver, first, second, third, fourth. Remember, first, ऊपर से start करो, uterus का fundus. First, second, third. It is starting ऊपर से. First, then on the side, second, then नीचे pelvis, third. So remember, first is fundus. Second is sides. And third is नीचे, that's the pelvis part. So the first is fundal palpation, second is lateral palpation, third maneuver is what is called as Pavlik's grip. The Pavlik is the third. Remember, Pavlik is when we are in the pelvic. Pavlik is pelvic one. Third. What is the difference between this Pavlik, the third and the fourth? दोनों में हाथ pelvis में है. The difference is facing the. So 1, 2, 3. Basically, you are starting like this. 1, 2, 3. You are facing the head end of the patient. The examiner is facing the head end. Now, when the examiner turns, comes towards the foot end, and then the two hands are coming from here. That is when it is the last one. That is the fourth. So foot end wala is the fourth. When the examiner is facing towards the foot end, that is the fourth maneuver. Right, so this is 1, 2, 3, 4. The Lipol maneuvers, Pavlik is third. Remember that. Coming to vaginal infections, which is very, very important topic, where you have bacterial vaginosis, trichomonas, and candida. What kit is used here? STI kit? 2. B is 2. Right? B is 2. What is the color of this STI kit 2? It is green kit. Green kit. What does it contain? Second kit contains secnidazole plus fluconazole. Candida wala fluconazole and secnidazole. So metronidazole, secnidazole, because this is the drug given for both bacterial also and trichomonas also. It's active against both. और candida को cover करने के लिए fluco. So in which of this do you see the green vaginal discharge? Trichomonas. Where do you see itching is absent? Bacterial. Where do you see curdy discharge? Candida. Where do you see strawberry cervix? Trichomonas. Where is the acidic pH? pH less than 4.5? Candida. All these points are what you need to see to make a diagnosis. So remember that. Talking about the important features first, bacterial. So in bacterial, you have A, B, C. In bacterial, it is A, B, C. What criteria? Amsel's criteria is for bacterial. So Amsel's criteria, bacterial vaginosis. What else does it have? Clue cells. Very, very important. So remember that Amsel's clue cells is bacterial. Bacterial vaginosis is basically because of just the altered flora. So there is no inflammation, that means no WBCs, that means no itching. Is there a fishy odor? Yes. So remember it as telling someone, you fish, and the other person says, no bitch. So fishy, you are fishy, but no itch. You fish, no bitch. So no itch, fishy, bacterial. How do you identify the clue cells? Clue is like glue. The cell sticking here, the epithelial cell sticking here. This is clue cell. Right? The clue cell. For trichomonas, remember trichomonas TR has all the TR, TR, TR. Strawberry cervix, drug of choice, metronidazole. Is there a cyst stage? No, only trophozoite. Is there a sexual transmission? Yes. So you need to treat the partner because it is sexually transmitted. Is this trichomonas? Is this giardia? Trichomonas. Why not giardia? Giardia is di, paired nucleus. This is single. What else do you have here? Undulating membrane. TU, trichomonas undulating membrane. What is this? Strawberry cervix, seen in trichomonas. What is the discharge color in trichomonas? Green. Right, so remember that it's a strawberry. और strawberry में फिर leaf, it's a green discharge coming out. Strawberry का leaf is the green discharge. Or you can also remember for trichomonas all the TR. It is a tree colored, that is green color. Right, it's a green color. Tree is green. Trichomonas green. So all the TRs help you remember the properties. This is curdy, thick, white, curdy candida. Everywhere candida white, curdy white discharge, white oral plaques, which are scrapable or non-scrapable? Scrapable. Does candida give glucan test positive, negative? Positive. Candida is glucan increased. What phenomenon does it show? Candida albicans. Remember Candy, Reynolds Broad phenomenon, the germ tube formation. So Candida is the one which has acidic pH less than 4.5. Remember Candida is very candid with acid. It's very candid with acid. So it likes the acid. Acidic pH is Candida. Candid with acid. So green discharge, green tree, trichomonas, curdy white Candida. Bacterial is thin yellow discharge. No itching, no bitching. Bacterial. Treatment, metro in trichomonas, metronidazole, alternative is clindamycin, because both these drugs are basically active against anaerobes. Metroclinda. And here it's fluconazole. Right? Azole, antifungal, candida ke liye azole. So this is about vaginal infections. Coming to the next one, ovarian tumors, important from pathology point of view as well. So what bodies, what markers do you see in the various ovarian tumors? Very, very important. So in ovarian tumors, the classification is epithelial, sex cord stromal, germ cell tumors. The most important that you should know here, which are epithelial tumors, which are germ cell tumors, battery ja raha hai mic ka, which are epithelial, which are germ cell. So remember that serous, mucinous is epithelial or germ cell. Important है ये पता करना, ये ऐसे ही बता दूँ. क्लास में जितना भी बताया है उसमें से सब कुछ important है. Right? Short means short. You have to know it. So when I'm telling you its classification, that means it's important. It has been asked in one of the recent INICT exam as well. Right? So epithelial tumors, germ cell tumors. Epithelial means like the type of epithelium. So you talk about serous, mucinous, clear cell. Bladder ka epithelium is what epithelium? Transitional. So remember transitional epithelium in bladder, which is what tumor? Brenner. Brenner is bladder transitional. And the endometrioid. So basically we are talking in epithelial, imagine like about the type of lining. क्लियर है कि सीरस है कि म्यूसिनस है कि एंडोमेट्रॉइड है कि ब्लैडर वाला है. The question asked in the INICT exam was this: clear cell tumor is your what tumor? Epithelial, not germ cell. So epithelial lining. The types of lining: clear, serous, mucinous, bladder. Germ cell. Basically, germ cell, reproduction, pregnancy, fetus. It is all related to pregnancy and the development of fetus. What do you see? So you remember the terms like that? This germinoma itself tells you it is germ cell. Endodermal. Fetus में endoderm आएगा. So endodermal sinus tumor, which is also called as yolk sac. So yolk sac pregnancy में आएगा fetus, right? Next is embryonal, embryo fetus. Polyembryoma, choriocarcinoma, chorioplacenta, right? Teratoma. Teratoma is the tumor which arises from all three germ layers. So again the germ layer, so it is also germ cell. Right? So easy yaad rakhna, which are the germ cell tumors? Dysgerminoma, embryonal, polyembryoma, endodermal, teratoma, choriocarcinoma, yolk sac tumor. So whatever is related to germ cell, reproduction, fetus, pregnancy, that is your germ cell tumor. बाकी बचा कौन सा इंपॉर्टेंट? हमारी granulosa cell tumor is what kind of tumor? Neither epithelial nor germ cell. So this is sex cord stromal tumor. It is like the supporting cell. So जो भी supporting cells है, supporting stroma है, it is sex cord stromal tumor. Stroma में आता है fibrous tissue, fibroma, thecoma, Leydig cell, Sertoli cell, granulosa cell. So sex cord and stroma. So remember it like this. You'll remember the tumor names better. Fibrous, thecoma, granulosa, Leydig, Sertoli. It's all the sex cord stromal tumor. The yolk sac tumor is also called as endodermal sinus tumor. The bodies that you see here are which bodies? Schiller dual bodies, or it is also called as glomeruloid body. Tumor के भी दो नाम है, bodies के भी दो नाम है. So remember, it is yes G. The mnemonic is yes G. Right? So if I call someone, वो अंग्रेज में बोलेंगे yes और हिंदी में बोलेंगे हाँ जी. Yes G. Yolk sac is endodermal sinus, has Schiller dual, has glomeruloid. Yes G. It gives you all the four terms. So that was about classification. Coming to the tumor markers and the bodies. CA125 is your marker for which tumor? Epithelial, germ cell, epithelial. When I say CA, actually it's a carbohydrate, but for our mnemonic, we'll remember that it's a carcinoma, which is coming from the epithelium. Carbohydrate, but it is carcinoma, epithelium. So CA125 will not be raised in your yolk sac tumor. It will be raised in epithelial ovarian tumors, that is serous mucinous. CA carcinoma epithelium. Alpha fetoprotein. When I say it is fetus, कौन सा ट्यूमर होगा अल्फा फीटोप्रोटीन? कौन सा ग्रुप? epithelial, germ cell, sex cord stromal, germ cell. Fetoprotein, fetus वाला germ cell. So alpha fetoprotein is your marker for germ cell tumors, but except in which one you do not have alpha fetoprotein? Dysgerminoma. So for germ cell, you have alpha fetoprotein, but dysgerminoma is different. DPL देखा था, Delhi Premier League. For dysgerminoma, it is flat LDH. Similar markers in the male you would see in seminoma. Right, so dysgerminoma is flat and LDH. The marker for your granulosa cell tumor, granny. What is the age of the granny? 99. CD99, which is MIC2. CD99 और कहीं देखा था? Kevins. उसमें ट्रांसलोकेशन कौन सा देखा था? 11, 22, सब डबल डबल. 22, 11, 22, 99. What bodies do you see in granulosa cell? Collex. It has coffee bean nucleus, pseudo-rosette appearance. The tumor marker is inhibin B. So remember it as this is our granny. How is our granny? Excited. है ना, बुढ़ापा आए लेकिन जोश न जाए. That's how our granny was. So granny is very excited. She calls her friends, calls even her exes. Right? बहुत जोश. She calls the exes. आ जाओ over a cup of coffee. And the ex gets the roses. Can you inhibit the granny? नहीं. Inhibit नहीं कर सकते. So inhibin B is the marker here. So granny excited calls the ex for coffee. The ex gets the roses, and you cannot inhibit granny. है ना, ब्रूटन भी उसको रोक नहीं सकता. तो she calls, किसको बुलाती है? Ex लेशनिहा, right, the extramarital granny का. For choriocarcinoma, choreo मतलब chorion placenta. What comes from placenta? HCG. So what is the tumor marker for choriocarcinoma? HCG. अभी तो देखा choriocarcinoma HCG is high, right? The malignant one GTN. So these are your ovarian tumor markers. Remember, inhibin is granulosa, FLAP and LDH is dysgerminoma, yolk sac tumor. What is the tumor marker for yolk sac? Alpha fetoprotein, fetus wala. So we have seen this tumor markers: inhibin granny, alpha fetoprotein, embryonal germ cell है, dysgerminoma का अलग है, ठीक है? Tumor markers done. Coming to the bodies. Where do you see samoma bodies? Serous. Remember, samoma is seen where all? P is which thyroid? Papillary thyroid, papillary renal, any papillary. S is serous. M, meningioma. M, mesothelioma. It is also seen P is prolactinoma. Meningioma was what marker for meningioma? Desmin. क्या था? मेनिंजियोमा का मार्कर डेस्मिन था क्या? Remember Vimentin, all the MEs, mesenchymal, meningioma, endometrial. Revise करोगे याद रहेगा. Right? So remember, meningioma has its Vimentin positive. So serous has samoma bodies. Schiller-Duval, कहाँ देखा Schiller-Duval? Yolk sac. Schiller-Duval is also called as glomeruloid. Yes, G. Lymphocytic infiltration. ये कुछ अलग ही है, कोई बॉडी नहीं है, ये डिफरेंट है. Different marker, different appearance. This is dysgerminoma. So even in the testicular tumor, if they tell you that there is lymphocytic infiltration seen, it is seminoma. So dysgerminoma, seminoma. Brachydactyly protuberance, dermoid teratoma, Paul Lexner, granny, granulosa. Rinky's crystal. Remember, Rinky's crystal appears like this as a cylinder, like this L. Right? L जैसे होता है. So it is L, Leydig cell. Rinky's crystal is Hylas cell or Leydig cell. Right? That's the same, Leydig or Hylas. Walthard cell nest. मतलब उसमें ऐसा नेस्ट नेस्ट दिखेंगे, ऐसे मल्टीपल फॉलिकल फॉलिकल नेस्ट जैसा. नेस्ट, वॉल्थार्ड सेल नेस्ट. इसका नेस्ट होता है बर्ड का, ब्रेनर का. बर्ड ब्रेनर नेस्ट. Signet ring is which ovarian tumor? Ring, a ring which has become crooked. है ना? रिंग छोटी होगी, जबरदस्ती पहनोगे crooked हो जाएगी. Crooked ring, Krukenberg. Krukenberg is the metastatic tumor of ovary. Metastasis to the ovary, is it unilateral, bilateral? Bilateral. It comes from the GIT, the gastric cancer. Bilateral metastasis coming from the gastric cancer is Krukenberg tumor. The ovarian shape is not changed. Hobnail is which tumor? Remember the nails and the hooks. What do you use the hook for? Hook का के लिए use करते हैं? Clear the space. So nail and hook is for clear cell. Hobnail is clear. Right, so these are your bodies. Coming to the images. Paul Exner has what appearance? Pseudo rosette. Where do you see true rosettes? Exner winter senior कहाँ दिखता है? Retinoblastoma, right? True is true Flexner, true friend. True is Flexner, friend. Retinoblastoma. Paul Exner is pseudo rosette. When I say pseudo rosette, basically means कि इसका center खाली नहीं है. So pseudo rosette, basically in the center there will be this pink material, and surrounding that you will see the cells arranged. That is pseudo rosette appearance. The nuclei will have the coffee bean appearance. Something which can look similar to Paul Exner is Schiller-Dubel, glomeruloid. But the difference here is because it's like a glomerulus. So बीच में capillary है, you have the visceral layer and the parietal layer, and what do you have in between the two? The Bowman space जैसी खाली जगह. So there will be double layer with the space in between. So if you look at only this part, this looks like the Paul Exner, but beyond that you have like the Bowman space, and then you have the second layer. So this is glomerulus wala, glomeruloid, Schiller-Dubel. So you will see this prominent here, the Bowman space. This is teratoma, Brockitansky protuberance, which has all three germ layer derivatives. Hair हो सकता है, teeth हो सकता है, कुछ भी हो सकता है in teratoma. Where you see this, what appearance? क्या ये? Nest. Nest is Walthard cell nest. Seen in bird Brenner. Where you see this signet ring is like this. Basically the nucleus is going to the periphery because यहाँ पे सब पूरा mucin होता है. So signet ring has the cells which has the peripheral nucleus. Signet ring, Krukenberg. Where you just see the appearance like this, the Rinky's crystal, Leydig. L, Leydig, Hylas cell. Right? It is just like the L. Hobnail. Nail is for clear cell. What is this? Samoma serous. Samoma is serous. और ऐसा और कहाँ देखा था? कौन सा लंग कैंसर? Squamous cell. Remember the keratin pearl. Keratin is keratinized squamous epithelium. Squamous. What was the other marker for squamous? P, right? The P one. P43. Remember pearl and the PP markers were for squamous cell carcinoma. Which lung cancer is synaptophysin positive? Small cell, right? Neuro. So this completes your ovarian tumors, an extremely important topic, actually pathological topic, right? Coming to the last one here, contraception. Important points in contraception, identifying the images. This is copper T, concept. Copper T, 380A. What does the A stand for? Arms में there is copper. So जो copper T में you would see that the arms are also containing the copper. It is 380A. Copper T 380A. What generation IUCD is it? Second, first, third. Second generation. It's a second generation IUCD. Why second? Copper content. Third generation, hormonal. Right? So Mirena, which is levonorgestrel containing, it is third. कुछ भी नहीं है तो first. So example of first, Lippes blue. Are IUCDs an example of lark? Are these lark? Your one of the exam question. Is this a lark? What is lark? Correct. Long acting, but reversible. It's a long acting reversible contraceptive. So will IUCDs come under this? Yes. They are long acting for years, but you remove them, it is reversible. Your sterilization techniques, will they be lark? Sterilization is irreversible. Copper T388, what is the lifespan? 10 years. Right? Maximum 10 years. Next is, this is Mirena, which contains levonorgestrel. So this is third generation. How do I identify it is? I will not see any copper here. Right? There will not be any copper and it will be like this curve. दूसरा कौन सा हो सकता है थर्ड जनरेशन? एक है मेरेना और दूसरा किसमें है? दूसरे में हार्मोन प्रोजेस्टेरॉन कंटेनिंग. तो वो कैसे दिखेगा? वो भी ऐसा ही दिखेगा, कुछ कॉपर नहीं होगा. बट जो प्रोजेस्टेरॉन है, प्रोजेस्टेरॉन will be more like the flat horizontal limb. It is like a T. Mirena is like curved. Next one, so levonorgestrel, this is LNG containing. The total is 52 milligram and daily it releases how much? 20 micrograms. Right, so it is LNG 20, releasing 20 micrograms per day. What is this IUCD here? Multi-load 375A, identified by multi-load. उसमें ऐसे multiple दिख रहे हैं, ठीक है, ऐसे multi-load. This is this a progesterone? No, because I see some metal here. It is not a Mirena, it's not a progesterone, there's some metal. This is called as Nova T. Nova T is a new IUCD which contains silver. Then silver भी होता है. So Nova T versus copper T 380A. 380A will have the आर्म्स में कॉपर, मल्टी लोड में ऐसे मल्टीपल होंगे, और नोवा टी में you will not see here in the arms, right? So this is nova tea, which contains copper and silver. This is centchroman tablets. Chaya. Chaya, C for C, contains centchroman. Antara contains DMPA. So Antara is DMPA, Chaya is centchroman. The advantage with centchroman is it is non-steroidal. So can I give in a patient of breast cancer which is dependent on steroid causes the growth, estrogen receptor? Can I give in breast cancer? Yes, that's the advantage there. OC pills नहीं देंगे, but ये दे सकते. For emergency contraception, levonorgestrel, how much is the dose? कितना? 1.5 milligram. You can give 1.5 as a single dose or 2 doses of 0.75, which makes it 1.5. These 2 doses are given to be 12 hours apart. Second, what is the most effective for emergency contraception? Copper T. Most effective is copper T, can be inserted till 5 days. What else can we use for emergency contraception is ulipristal. Remember, ulipristal can also be used. Ulipristal is progesterone. This is SPRM. Like you have SERM, which is tamoxifen. This is selective progesterone receptor modulator, that is ulipristal. OC pills are contraindicated in cardiac disease, DVT, even liver disease. Because when the patient is taking OC pills, it is what state? OC pills is a hypercoagulable state. So not in DVT, not in cardiac, thrombosis नहीं चाहिए, liver में भी नहीं, क्योंकि OC pills liver में कौन से ट्यूमर एसोसिएटेड है? Hepatic adenoma. Hepatic adenoma. So basically in these you can use IUD. When there is vasectomy, so we need to use a contraceptive method even after vasectomy. It is not immediately effective. It is not immediately effective. So you need to use complement, some other form of contraception for how long? 3 months. Right? So for 3 months or 20 ejaculations. What is this? We have seen this. Molar, snowstorm, molar. We have seen this. Property, treaty, A. Mirena, Chaya. Right, this we have already seen. Coming to the next one. What is this? Is this PCOS or is this ovarian hyperstimulation or is this Zika lutein cyst? PCOS. Why? Look at the ovary. What does it have? follicles. Where? Periphery. All the follicles are in the periphery. So remember, PCOS has peripheral follicles. Why peripheral? What tells the follicles in PCOS you are not supposed to be in the center? You have to go to the periphery. Stroma. The increase in the central stroma. The central stroma is increased. So remember, in PCOS, there is increased central stroma, which tells the follicles, this is my space, you go in the periphery. Why does the central stroma increase? Because this is androgen dependent. There is increased androgens in PCOS. What is the clinical feature which tells me that yes, there is increased androgens? Hirsutism. Right? There is hirsutism which tells me that there is increased androgens. So PCOS female is generally obese or lean. Obese female. So obesity also increases the risk of metabolic syndrome. Right? Metabolic syndrome which has insulin resistance, and therefore in the treatment, metformin. Which antipsychotic drugs cause metabolic? Remember, zap करके weight बढ़ता है, clozapine, olanzapine. What are the side effects with metformin? Metabolic acidosis, B12 deficiency, methylcobalamin deficiency, right? So remember, metabolic syndrome, insulin resistance, so you need to give metformin also here. One more question asked here, in metabolic syndrome, you see the lipid abnormality, that is, what increases? Triglycerides. Hypertriglyceridemia. The first management here is lifestyle modification. Does PCOS patient have irregular cycles? Yes. Painful ki painless? Painless. Why painless? Anovulatory. The anovulatory cycles are painless cycles. It is irregular cycles. So to regularize the cycles, what can we give? OC pills. In PCOS, what increases? LH FSH or FSH LH? Increase LH FSH. There is increased LH by FSH ratio. All the follicles that you have in PCOS are less than 10 mm because PCOS is anovulatory. Anovulatory means there is no dominant follicle. Right? There is no dominant follicle here. So all the follicles are less than 10. The ovary is bulky, more than 10 cc volume. So this is about PCOS. What placenta is shown here? Is it filamentous? Is it battledore? Is it circumvallate? Is it circummarginate? This is लिखा है उधर filamentous. ठीक है? This is filamentous. But question है कि क्यों filamentous? In the filamentous placenta, the cord is inserted on the membrane. Membrane insertion. Why this is not battledore? Battledore is at the door, the margin of the chorionic plate here. जो battledore है वो यहाँ insert होके फिर bifurcation होगा. Here you are seeing the bifurcation happening well before that. So it is the membranous insertion. So this is filamentous. अगर यहाँ होता तो वो battledore होता. So filamentous placenta has the increased risk of vasa previa, which is maternal bleed, fetal bleed. Fetal. What test? AB test can lead to fetal distress. What investigation is this? HSG. Does it have radiation exposure? Yes or no? Yes. Logically सोचो क्या दिख रहा है HSG पे? X-ray दिख रहा है, right? ये पूरा background में X-ray है और ये contrast है. So it's a contrast X-ray. So does it have radiation exposure? Yes. HSG day. What day of the cycle? Day? Sorry? Day 3 की day 7 की day 60 की day 21 की जब मर्जी है कर लो. 7. Why? Reproductive age female. You will not do anything which has radiation after day 10. There's a rule of 10 because risk of ovulation, fertilization, pregnancy. तो जल्दी करना, like before the ovulation. Day 3 वगैरह पे नहीं करेंगे because day 3 is still menstruating. The endometrium has not healed. You push the contrast, which can cause damage to the endometrium. So you wait for the menstrual period to get over, but you do not do it after 10 days. So it is like day 7 to day 9. Right? Remember, it's best done at that time. The primary indication of doing HSG is it to look for the uterine abnormality? कि भाई यूनिकॉर्न्यूट है कि सेप्टेट है कि बाइकॉर्न्यूट है. What do we do HSG for? It is not for the uterine abnormality. It is basically for the tubal patency, because this is the investigation which tells me whether the tubes are patent or not. The other one is the invasive one, that is chromoperturbation. जहाँ हम कलर डाल के डाई डाल के देखेंगे कि वो बाहर आ रहा है कि नहीं, बट वो लैप्रोस्कोपी में होगा. This is basically for tubal patency, whether the tube is blocked or the tube is patent. So in a patient of infertility, to rule out tubal block, we will do HSG. So primary indication is tubal patency. If the spill of the dye is present, so we cannulate the cervix, we push the contrast, and we take the X-ray. The dye that we are pushing, it goes from the cervix into the uterus, into the fallopian tube. And if the tube is patent, what will happen is the dye will come out. So you will see the spill of the dye. The spill of the dye will be present, which is normal. Tells you that the tube is normal, the tube is not blocked. The uterine abnormality that you are seeing here is unicornuate uterus. The unicornuate uterus basically is one horn, so it is deviated to one side, right? So remember, this is unicornuate uterus like this, which is also called as banana uterus, right? Unicornuate will be just one horn, it is banana uterus. What are you seeing here in HSG? ये गैप दिख रहा है कि यहाँ पे कॉन्ट्रास्ट फिल नहीं हुआ. This is the uterus का lining, but I see that in the endometrium there are areas where I'm not seeing the contrast filling in. So basically this is the filling defect, Asherman syndrome, where you will see the contrast filling defect. Asherman syndrome basically has endometrial adhesions. There are endometrial adhesions. So this is common after curettage. DNC, TB, these are common causes of Asherman. Okay, so affecting the endometrial lining, if you do the curettage, the endometrial lining is damaged, there is adhesion. TB causes scarring everywhere, so adhesion, TB. So Asherman syndrome, can it lead to amenorrhea? Yes, secondary amenorrhea हो सकता है, but यहाँ पे hormonal level सब कैसे रहेंगे? Normal. This one here is a uterine sound. Right, this is just a uterine sound, which basically helps us to see the uterus is anteverted, retroverted, right? So this is a uterine sound for the uterine uterus is retroverted or anteverted to see that. It also helps us to see the uterine perforation. है ना, अगर यूट्राइन साउंड आप डाल रहे हो यूट्रस में, वो अंदर जाता जा रहा है, दैट मीन्स इट हैज परफोरेटेड, दैट यूट्रस इज परफोरेटेड. When you see this black, the black bones, the black powder bone lesions on laparoscopy, this is endometriosis. What is endometriosis? Basically, the endometrium is growing into some other side. If it grows into the uterus itself, in the myometrium, then it is called as adenomyosis. अगर यूट्रस में अंदर जा रहा है तो एडिनोमायोसिस, और कहीं जा रहा है तो endometriosis. So it can go into the ovary. Yes, and then what can it cause in the ovary? Chocolates. Right, the recurrent hemorrhage, क्योंकि endometrium है ovary में, so with every cycle bleeding होगा, even in the ovary there will be chocolate cyst. Basically it is hemorrhagic cyst which contains hemorrhage. कोई fresh होगा, कोई old hemorrhage होगा, so different age hemorrhage. The powder bone lesion, because it can go into the peritoneum as well, right, deposits everywhere, and then it can lead to adhesions. Adhesions is mentioned everywhere, it causes adhesions. The clinical feature: dysmenorrhea, dyspareunia, and there can be infertility as well. The gold standard investigation is laparoscopy, where you would see these powder bone lesions. Right, the blood deposited, क्योंकि endometrium है वहाँ, powder bone lesions with adhesions. So endometriosis basically is a state of increased estrogen. So you will not give a drug which increases the estrogen. Versus in adenomyosis, what will you see? What are the complaints in a patient of adenomyosis? Very common. Adenomyosis. Endometrium अंदर जा रहा है. Uterus will be enlarged, bulky uterus. Clinical features will be menorrhagia. है ना, uterus के अंदर ही है. So imagine that all the bleeding is coming from the uterus itself. Menorrhagia, dysmenorrhea, the severe dysmenorrhea, menorrhagia. This female is around like more than 30-40 years. And the definitive management problem कहाँ है? Uterus में. The definitive management क्या होगा? Uterus निकाल दो. That is hysterectomy. The definitive management is hysterectomy. This is a CT, the white bone cortex. In the CT, there is some mass which is here. The thing that I want you to remember here is, if in a patient of CA cervix, you are seeing this. What is this? This is kidney. क्या दिख रहा है ये kidney में? Dilated. This is all gray color is the water. Remember on CT, the gray is the water. So telling you that there is hydronephrosis, hydroureter. So whenever you have CA cervix with hydronephrosis, hydroureter, it is what stage? Stage 3B. Remember, it is stage 3B, and the treatment here has to be CTRT, chemotherapy, radiotherapy. So the more advanced the cancer is, the more palliative treatment you give. जितना localized है, you do the surgery and remove it. It's easy to remove a localized cancer. जितना spread हुआ है, उतना आपको systemic पैलिएटिव ट्रीटमेंट देना पड़ेगा. This is the outlet forceps. Wrigley's forceps is the outlet forceps which is used when the fetal station is high to low. Fetal station is low. What is contraindicated in a premature or preterm is forceps ventouse. Ventouse. Because there is increased risk of bleed forming here. Premature में remember bleed का risk, hematoma का risk ज़्यादा है. Yes, that completes your OBGYN.